Welcome to part 4 of pulmonary drugs. This is Dr. Phyllis Dumont. Corticosteroids by the inhalation route have little impact on the HPA axis. However, high-dose inhaled steroids may be absorbed sufficiently to inhibit growth. So in pediatric patients, it's important to monitor that. It's also important to remember and balance that with the knowledge that uncontrolled asthma also inhibits growth. Inhaled corticosteroids. Inhaled glucocorticoids, another word for steroids, glucocorticosteroids, corticosteroids. These are substances which suppress airway inflammation by activating anti-inflammatory genes, by switching off inflammatory gene expression, and inhibiting inflammatory cells. Inhaled corticosteroids are contraindicated in acute bronchospasm, whereas oral or IV steroids may be indicated. The actual particulate in the spray for the inhaled corticosteroids can worsen bronchospasm. The prototypes of inhaled corticosteroid medications, we'll talk about 3, beclomethasone, which is in brand name Qvar in the MDI inhaler, or Becanase in a nasal spray, is not very well absorbed by the inhalation route to the systemic circulation, or less than 5% of it will reach the systemic circulation, so its effects are all local. Budesonide or Pulmicort, about 10% reaches the systemic circulation. Fluticasone or Flovent MDI or Flonase nasal inhaler, as much as 30% can reach the systemic circulation. Beclomethasone can be used in children ages 5 and up. Pulmicort is indicated for children age 12 and up, and it has the fastest onset of effects. And fluticasone can be used in children age 5 and up. Other agents which impact inflammatory processes and help to improve asthma include the mast cell stabilizers. The prototype for this is a cromolyn sodium, or Intal. Intal as a metered-dose inhaler is no longer available in the United States. This substance prevents mast cell degranulation and thereby preventing the release of histamine and slow-reacting substance of anaphylaxis. So it has an anti-allergic and an anti-asthma effect. It also prevents the release of leukotrienes, which inhibits eosinophil chemotaxis. And chemotaxis is another word for inhibiting the influx of eosinophils. It's a chemotaxis which causes or calls the eosinophils into the lung in response to something that triggers inflammation, and cromolyn sodium will prevent the release of these, so it will inhibit that eosinophil chemotaxis. It will not reverse bronchospasm and the effects of histamine or the effects of vasoconstriction. So it prevents the cascade that leads to the release of histamine and the histaminic effects. But once the histamine is present and once vasoconstriction has happened, it won't do anything to reverse that. So pre-medicating with an inhaled beta agonist can prevent cromolyn-induced bronchospasm. Some people are sensitive and get a little bronchospasm results to the inhaled cromolyn. If you use a short-acting beta agonist beforehand, that will help prevent that bronchospasm. It has little to no systemic absorption, no significant drug interactions. It often takes 2 to 6 weeks to see the results. It can be used in children 5 years old and up, and the dose is a 20 milligram ampule used in a handheld nebulizer, QID. Again, it's no longer available as an MDI. It's very useful for cold-induced or exercise-induced bronchospasm, often prescribed 2 puffs 10 to 15 minutes before exposure, and sometimes, of course, you precede that with the short-acting beta agonist. Unfortunately, now that it's not an metered-dose inhaler, it's not convenient to cart around the handheld nebulizer, so it's not used as often as it once was for pre-exercise use. So, the treatment principles of asthma. In our treatment of asthma, the management strategy is based on the severity of the asthma. So the first thing that has to happen is you have to assess the severity of the asthma, and And generally, asthma is thought of as being mild and intermittent, mild and persistent, moderate and persistent, and severe and persistent asthma. And a stepwise approach is recommended. So if control is not achieved, the first thing you have to do is reevaluate for compliance and administration factors, because if the patient is not utilizing the handheld nebulizer or the metered dose inhaler correctly, or they're not using the medication as directed, then they need to be re-educated on those factors, and you need to reevaluate after they've given improved compliance a chance. But if it's appropriate, then you go to the next higher step. And likewise, you can consider gradual step downs in treatment. You can consider backing down in the level of treatment about every 1 to 6 months if the patient has achieved adequate control. One for controlled asthma, we have a rescue medication and no daily medication. So this is the intermittent asthma, and with intermittent asthma, the patient is only experiencing wheezing on occasion, and then a rescue inhaler alone would be effective to treat that. Step 2 is for controlled to partially controlled asthma. So you continue to use the rescue inhaler, the short-acting beta agonist, as needed, but you add either low-dose inhaled corticosteroid, cromolyn, montelukast, or theophylline as a daily stabilizing drug for the asthma. If a control is not achieved with that, or it's only partially achieved, then you would move on to step 3, which is the same as step 2, but you could consider adding a low-dose inhaled corticosteroid plus a long-acting beta agonist. They would still have their rescue short-acting beta agonist. Or you could add a leukotriene antagonist, or theophylline, or a medium-dosed inhaled corticosteroid. Now, you're not expected at this point to memorize all of these steps, but you should recognize the general pattern of increase. Also, you should realize that at step 3, at this point, we're often referring, and it's recommended that you consider referring to an allergist or a pulmonologist when you cannot get control with step 2. You should definitely have considered referring, and you can go ahead and read through the further steps. Principles for COPD are similar. Bronchodilators are primary to symptom management, however. All patients with COPD need a short-acting bronchodilator as a rescue inhaler. That can be either a beta agonist or an anticholinergic agent. For patients who are not on a long-acting anticholinergic agent, a combination of a short-acting beta agonist plus a short-acting anticholinergic, rather than either one alone, will achieve a greater acute bronchodilator effect. For patients who are on a long-acting anticholinergic agent, a short-acting beta agonist is needed for quick relief of COPD symptoms. For COPD patients who are on an optimum long-acting inhaled bronchodilator regimen, but who still have persistent symptoms or repeated exacerbations, you can add an inhaled glucocorticoid. If a patient is on a long-acting beta agonist, you can add the glucocorticoid alone. If a patient is on a long-acting muscarinic agonist, such as tiotropium or Spiriva, you can add a combination of an inhaled steroid and a long-acting beta agonist. Indications for earlier use of inhaled steroids would include a history of asthma or a clear allergy component that's exacerbating the patient's symptoms. Otherwise, for COPD as well as for asthma, influenza and pneumococcal immunizations are strongly recommended. For exacerbations, we can consider increasing the dose and frequency of short-acting bronchodilators, systemic corticosteroids, and antibiotics if purulent sputum develops. For the prevention of frequent exacerbations, the Daliresp may be indicated. So the following is from a slide that's available on UpToDate that kind of summarizes the evidence for decision making in terms of the stepwise approach to asthma. You can go ahead and read through that, but you will not have any direct questions from this slide. The information on the slide is covered in some of the other slides, and it might come from another slide, but there won't be a direct question related to this slide. So this is an example of a chart of the stepwise approach for managing asthma in youths greater than or equal to 12 years of age. And you'll notice that it's at around step 3 that you consider a consultation with an asthma specialist. But if you get to step 4, then you definitely need a consultation with an asthma specialist. And here's this is really more the diagnostic severity. You won't have a question directly related to diagnostic severity because that's not a pharmacology question. But if you're curious about how do we determine what step you're on, this chart summarizes the diagnosis of each level of severity. And here's one for younger children.